Hi, everyone. So I see people are still joining, but we are going to get started. So good morning, good afternoon, and even good night for some of us. My name is Tamara Tobin. I am the founder of Urge Medical. We are a nonprofit dedicated to providing medical education to doctors and other healthcare providers on the topic of persistent and recurrent UTI and related conditions. Urge's mission is to help improve the lives of patients who are suffering from persistent UTI, a condition that is often misdiagnosed and misunderstood. And chronic UTI support groups are full to the brim with patients who are desperate for medical care. So Urge exists as a platform where the top specialists on the topic can share their knowledge with doctors at large, such that doctors are empowered with the knowledge and tools to treat more patients. All of our content is free of charge, and I invite you to visit the website for updated science-backed information and upcoming webinars. I am so happy to welcome you here for our first introductory webinar of Urge's webinar series, which hopefully is the first of many. We've had a tremendous response from people all over the world. I can see more and more people joining as we speak. And I would especially like to thank our partners at Live UTI Free and the Israeli Bladder Association for helping to spread the word. And if you know of any associations that you think might be interested in partnering with us, that might be interested in the educational content that we're sharing, please let me know. It gives me great pleasure to welcome our guest speaker for today, Dr. Michael Hsieh. Dr. Hsieh is the Director of Transitional Urology at Children's National Hospital and George Washington University in Washington, D.C. He is also the Stirwalt Endowed Director of the Biomedical Research Institute, where he runs a bladder biology research group and is developing a broader microbiology research program across multiple labs. Dr. Hsieh holds an MD as well as a PhD in immunology and is a recognized doctor on the Healthgate's Honor Roll and Best Doctors in America. He's been featured several times in the New York Times for his work in robotic surgery and bladder inflammation. He has written over 110 peer-reviewed papers. He's the chair of the American Urological Association Research Advocacy Committee, which includes patient groups such as Live UTI Free, which is the largest patient advocacy group on UTIs in the world. He is a fellow for the American Society of Tropical Medicine and Hygiene. He sits on the board of directors of the Interstitial Cystitis Association. And I am so excited to hear this really exclusive talk today, where he's going to be talking to us not only about how to diagnose and treat UTI associated with negative urine cultures, but also sharing some of the research that he's doing at his lab. So before we get started, I invite you all to submit your questions in the chat. You are only going to be able to submit the questions to me, and then I will be sending those on to Dr. Hsieh, and we will address as many of them as possible at the end of the program, which is in about 40 minutes. So about 40 minutes of presentation, about 20 minutes of chat. And without further ado, Dr. Hsieh, the floor is yours.
Okay, well, hello everyone. Thanks for joining me today. Let me share my screen. Can everyone see my screen?
Yes, we can see your screen, Dr. Hsieh. Thank you.
Okay, great. I'm just starting presentation mode. So I outline today's talk.
Was always predetermined.
Sorry, Dr. Hsieh, you're muted. Would you mind unmuting?
Okay, sorry about that. Not sure what happened. So just to outline today's topics, first of all, I'm going to go over the medical opportunity in terms of providers, the definition of recurrent and persistent UTIs, limitations of conventional urine cultures, and how to treat persistent and recurrent UTIs. So a brief word about my practice and how it relates to this talk. So I am a fellowship trained urologist with a PhD in microbiology and immunology. And I'm fortunate enough to run an NIH-funded research group focused on UTIs. I see both pediatric and adult patients, with many of the children I see prone to UTIs, and the majority of my adult patients suffering from this condition. So what is the medical opportunity for us as providers? First of all, there are many patients who have recurrent and persistent UTIs, and very few providers who are well versed in managing these patients. So investing some time to learn how to diagnose and treat this patient population is well worth it. I myself have noted a significant uptick in my practice volume from taking care of this patient population. So what are the definitions of persistent and recurrent UTI? The American Urological Association issued guidelines for recurrent uncomplicated UTI in 2017. And in those guidelines, recurrent UTI was defined as 2 separate culture-proven episodes of acute bacterial cystitis, in other words, bladder infection, and associated symptoms within 6 months, or 3 episodes within the same year. As for persistent UTI, for this talk, I'll define it as UTIs that do not resolve within several days with or without treatment and or recur. In terms of symptoms of persistent and recurrent UTI, I won't dwell on specific symptoms since this audience is familiar with them, but I did want to emphasize that there's a tremendous range in specific symptoms between patients and sometimes even between episodes in the same patient. And there's also a range in type as well as duration of symptoms. A complicating factor is that even in patients who have cleared their UTIs, symptoms resembling a UTI may continue, possibly due to bladder injury from a UTI that takes time to heal. So UTIs are quite common, with half of all girls and women having at least 1 episode in their lifetimes. And half of this number, unfortunately, will suffer from multiple UTIs. Among males, older men with prostatic enlargement, as well as uncircumcised boys, are also at increased risk of UTIs. And a poorly quantified proportion of all of these patients will develop persistent UTIs. So next, I'd like to talk about shortcomings of conventional urine cultures. Although conventional urine cultures work for the vast majority of patients with uncomplicated UTIs, for other patients, conventional cultures feature a high false negative rate. So several studies, for instance, have reported that in children with DMSA scan proven pyelonephritis, kidney infection, as many as 17% of these patients have negative urine cultures. Other work has shown that in women, cultures may be falsely negative in up to 45%. Another hint that conventional urine cultures are imperfect, like any test, is that UTI symptoms persist in about 1 in 5 women with post-antibiotic urine cultures that are negative. And this has been shown in a number of studies. Finally, compared to enhanced quantitative urine cultures, which I'll go into more detail shortly, conventional urine cultures miss a significant proportion of uropathogens. So how is it possible that conventional urine cultures lead to false negative results? If you dig into the original literature on urine cultures, you'll find that the test was developed over 6 decades ago to diagnose only E. coli pyelonephritis and not other bacteria, let alone cystitis. Other works shown that setting the CFU threshold for UTIs as greater than 100,000 CFU per ml is too high, and I'll highlight some of that literature later. There's also substantial research that verifies that standard cultures do not detect bacteria that are in biofilms, intracellular bacterial communities, which I'll describe later, or bacteria that are viable, in other words, alive, but not culturable. Now, I mentioned intracellular bacterial communities in the last slide, so let me present data that explains what this is and supports this concept in UTIs. So the historical view of cystitis is that bacteria is floating in the bladder lumen, in other words, floating in the urine in what's called a planktonic state. And that this is the only anatomic location of pathogens in the bladder. So it turns out that E. coli, which causes most episodes of UTI, as well as a number of other uropathogens, can actually invade the urothelial cells that line the bladder and form what are called intracellular bacterial communities, or IBCs. So here's an image of a red-stained urothelial cell in panel B with green IBCs. And the panel C just shows the merged image to confirm that there's co-localization. So another research group has confirmed that this is a real phenomenon. What I'm showing you here is that the white arrowheads are pointing to green fluorescent bacteria embedded within the bladder lining, the urothelial lining. So what's hypothesized to occur in some of these patients with recurrent or persistent UTI is bacteria are hiding from antibiotics and the immune response by creating IBCs, and then they emerge to restart infection when they sense that danger has passed. This life cycle of IBCs might also explain why conventional urine cultures can be negative in patients with persistent UTI symptoms. In addition, it turns out that tissue-resident bacteria in the bladder can be different than the planktonic bacteria that are detected by standard urine cultures, as shown here in this table of patients with a history of UTI. So this suggests an explanation why some patients with UTI don't have improvement in their infection-associated symptoms, even after what seems like appropriate antibiotic treatment based on standard urine cultures. So how does one diagnose persistent and recurrent UTI associated with negative conventional urine cultures? Options that I'll describe include enhanced quantitative urine cultures, molecular methods to detect bacterial DNA in the urine, use of lower CFU thresholds on cultures, and very importantly, patient symptoms. So for instance, in terms of the last consideration, in my opinion, bacteriuria, the presence of bacteria in the urine, regardless of how it's diagnosed, should not be treated if a patient is not having symptoms, except for very specific circumstances such as pregnancy and upcoming urologic surgery. So I promised earlier to define enhanced quantitative urine cultures, or EQUC, so let me do that now. Conventional urine cultures rely on a very narrow range of media and growth conditions that work very well for detecting E. coli and a few of the other common uropathogens. So this works for most, but certainly not all patients. EQUC, in contrast, uses quite a few different forms of media and growth conditions to capture a wider possible range of possible uropathogens. So to briefly go into some examples of the specifics, standard cultures tend to be incubated for shorter periods using forms of media such as blood agar and McConkey under aerobic conditions, which is, again, great for E. coli and a few other common uropathogens. EQUC, in contrast, tends to use longer incubations in anaerobic as well as aerobic conditions using a wider range of growth media. And this can detect more potential uropathogens. So to give you some data to support that, there are multiple papers supporting the superiority of EQUC over conventional cultures, but in the interest of time, I'll just highlight one of the seminal papers. So in this table, we have bacterial species in each row and different growth conditions in each column. So the numbers in the cells show how many times each uropathogen was successfully grown in the conditions listed. And these are patient samples, of course. and the conditions that best detected each pathogen is shaded. So for instance, the red box shows that E. faecalis is actually best detected using colistin malodixic agar in CO2, which is not part of standard urine cultures. In contrast, E. coli grows better in different conditions. So how do we know that EQUC might be clinically superior to conventional cultures? Because that's what us clinicians really care about. So in one study compared to EQUC, standard cultures missed about 2/3 of uropathogens, of which half were in patients who had severe symptoms. Over 1/3 of patients with pathogens missed by these standard cultures had no symptom resolution after being given antibiotics guided by standard cultures. Now, the study I just showed you only suggests that standard cultures are imperfect, but don't necessarily directly support the superiority of EQUC. So this paper addresses this latter issue. So in 225 women with UTIs were randomized to treatment based on EQUC or standard cultures. Now, not surprisingly, EQUC had a somewhat higher culture positivity rate. More importantly, there was a statistically significant, although modest, improvement in UTI symptoms as assessed by a validated questionnaire. So are EQUC the next standard of care? Perhaps, but I do think we need more studies to validate this test, and those publications are forthcoming. In addition, there's emerging evidence that molecular methods might have a role in diagnosis of UTIs. So the critical care literature has observed that as many as 68% of patients with life-threatening sepsis have negative blood cultures. And in this setting, molecular methods are often used to identify pathogens. So this raises the question of whether a similar role for molecular methods in diagnosis of other infections, such as UTI, may be useful. So there's two major forms of molecular methods to diagnose uropathogen-associated DNA in urine, and they are based on PCR, which amplifies the DNA in question, and then sequencing of 16S ribosomal RNA from bacteria. So 16S ribosomal RNA is a portion of bacterial genomes, the collection of all bacterial DNA, which is very different between most bacterial species. So it makes it a very attractive target by which to identify bacteria. A really important question is whether 16S ribosomal RNA sequencing, let alone PCR, is better than conventional urine cultures. So in a study of 44 patients, of which half were randomized to treatment based on standard cultures and the other half randomized to treatment based on 16S ribosomal RNA sequencing results, less than half of patients had positive cultures, whereas all patients had positive results by the 16S sequencing. More importantly, patients who were treated based on 16S ribosomal RNA results had a much better improvement in their UTI symptoms compared to patients treated with standard cultures. And this uses the same validated questionnaire that I showed you earlier for enhanced quantitative urine cultures. In terms of CFU thresholds for declaring a patient does or does not have UTIs, multiple studies have shown that relying on a threshold of more than 100,000 CFUs per ml is probably too stringent. So in terms of patient symptoms and history, I very much rely on how a patient is feeling currently, because there is a potential danger of these molecular methods, let alone standard cultures and EQUC of wanting to treat a patient who's not currently symptomatic and therefore is unlikely to have a UTI. So how do I diagnose persistent and recurrent UTIs in my own practice? I actually still consider conventional urine cultures as a gold standard in patients where they have consistently positive cultures while they're symptomatic. Okay, conventional urine cultures, again, works for most patients. That being said, myself and some other practitioners see patients with very complicated UTIs, and in that setting, conventional urine cultures may not be as useful. Otherwise, as a next step, I tend to use lower CFU thresholds as well as EQUC. The latter has probably the most evidence, even compared to the molecular methods, which are my next preferred modes of diagnosing UTIs. So which patients do I think benefit from molecular methods of diagnosing UTIs? It's those patients who consistently have negative urine cultures, but also have consistent improvement when given antibiotics. And of course, you know, this is somewhat a judgment call based on the individual patient. So I did want to briefly highlight some of the research in my lab that's pertinent to today's discussions. So a major and legitimate criticism of molecular methods to diagnose UTIs is that some or all of the detected bacterial DNA is from dead bacteria, which obviously don't cause infection. So this is called relic DNA, and it's a long recognized issue in other fields such as food and environmental microbiology. So the issue with relic DNA, as shown in this figure, is that if you detect DNA from dead bacteria in urine, one could end up misattributing patients' symptoms to that DNA and then inappropriately treating the patient. Well, it turns out there is a way to selectively detect only DNA from live bacteria. So Propidium monoazide is a dye that binds to free-floating DNA and DNA from lysed dead bacteria. So this dye inhibits PCR and therefore allows selective amplification of only DNA from live bacteria. So a huge advantage over conventional PCR. So we've successfully developed Propidium monoazide-based PCR in an E. coli specific assay. So using a mouse model of E. coli UTIs, we found that after treatment of these mice with ciprofloxacin, although most groups of these mice had negative standard cultures, our PCR assay detected live bacterial DNA in the majority of these groups of mice. So this suggests that, by analogy, perhaps some patients with post-antibiotic UTI symptoms associated with negative post-treatment cultures might still have live bacteria as a cause of their persistent symptoms. So we're currently developing this assay for clinical use. Early results confirm that the PCR assay has perfect concordance with positive urine cultures. In addition, it remains an open question whether this assay will be superior to cultures and other molecular methods to diagnose UTIs, but we're quite excited about its possibilities. So in the last part of this talk, I'd like to discuss methods to prevent and treat UTIs. Antibiotics remain the backbone of UTI treatment for many patients. The AUA guidelines that I mentioned earlier recommend no more than a week of antibiotics. However, I'd like to point out that these guidelines do not supersede provider judgment when managing individual patients. And in addition, many patients do not fall into the definition of recurrent uncomplicated UTIs. For acute uncomplicated cystitis, clinical trials support anywhere from single doses of antibiotics given orally from up to 3 to 7 days. Pyelonephritis, kidney infection, is commonly treated with longer courses of antibiotics, either orally as an outpatient in patients who are not critically ill, or intravenous antibiotics for more severely affected patients. Now, there are a number of forms of antibiotic prophylaxis to prevent UTIs, including a single dose after sex for patients prone to UTIs caused by coitus, as well as daily doses of preventive antibiotics. For some patients, self-initiated antibiotics can be helpful. And then as for patients with persistent UTIs, longer antibiotic courses may be necessary. Now, that being said, there's really a dearth of good quality medical evidence to guide exactly how long these antibiotic courses should be. There are a number of non-antibiotic options to help manage persistent recurrent UTIs as well. So one controversial option is electrofulguration with patients with antibiotic refractory UTIs. So this involves cystoscopic cauterization of inflammatory spots in the bladder that are harboring bacteria. So cystoscopy, of course, is endoscopy of the bladder. This has been demonstrated to result in improvement in the majority of women in some small studies. And for other women, multiple episodes seem to increase success rates. Now, this may seem like a radical procedure, but let's think about it for a moment. So for those of us who are urologists or gynecologists, we're familiar with bladder lesions like cystitis cystica, as shown here, cystitis glandularis, and squamous metaplasia of the bladder trigone. Okay, these lesions are thought to represent inflammation from UTIs. Right. So earlier in this talk, I showed you evidence that these lesions can harbor bacteria, which makes sense, right? Why would the bladder feature localized inflammation for no reason? So electrofulgurating these lesions, as shown here, has been, again, reported in several studies to improve patient symptoms. And in my limited experience with this procedure, no patients have had major side effects, and some have had dramatic improvement. So this is not a panacea. We do need more trials, but it is a potential option for appropriate patients. There are many other non-antibiotic based means by which one could potentially decrease UTI risk. We could talk for several hours at length about these means, but to highlight some of the most data-supported approaches, a randomized trial published in JAMA Internal Medicine showed that water intake of 3 liters daily was shown to greatly decrease UTI risk in premenopausal women who at baseline drank 1.5 liters of water a day or less. Methenamine hiprate, also known as Hiprex, at least in the United States, has been shown in multiple clinical trials to lower UTI recurrences. Vaginal estrogen for postmenopausal women also has a high level of medical evidence for UTI prevention. Now, intravesical antibiotics such as gentamicin has also been reported to decrease UTI risk, although most of the literature is in the neurogenic bladder patient population that is already catheterization dependent. Less supported approaches include use of vaginal lactic acid gel, intravesical installations of substances such as hyaluronic acid that are felt to restore a more normal bladder lining. And then a number of supplements such as D-mannose, cranberry products, and probiotics have limited clinical trial data to support their use. So what is on the horizon in terms of preventing UTIs without relying on antibiotics? There are very interesting studies looking at oral nanocides to reduce UTIs. There's also quite a few UTI vaccine candidates in advanced clinical trial testing. So although there's several commercially available oral UTI vaccines in Europe, which contain heat-killed bacteria that seem to decrease UTI risk, clinical trial data is limited, and immunity seems to fade after stopping these vaccines. So there is a real need for UTI vaccines that lead to lasting immunity, even if these currently available vaccines work while you take them. Now, fecal microbiota transplantation is also under active investigation with a limited number of publications so far. Now, despite this lack of evidence, transplantation is available in some parts of Europe. So in conclusion, persistent and recurrent UTIs are sometimes misdiagnosed as other conditions. Although these infections can be challenging to manage, there's many preventive and treatment options, and other options will become available. If you don't take anything else away from this talk, I would want to have you leave with the strong impression that conventional urine cultures are not an ideal gold standard to diagnose UTI for some patients, and that there is a large unmet patient need. So thank you for your attention, and I'm happy to answer any questions.
Thank you so much, Dr. Hsieh. I've just sent you some of the questions that we've received during this call. So I don't know if you've received them now.
Yes. Okay. Happy to answer them. So first question is, if standard cultures have such a high false negative rate, why is it still used? Well, again, I think it works for most patients, definitely not all patients, right? So obviously patients who have more complex UTIs, I think, are more likely to have negative cultures. There is data to suggest that's true. And also, medicine has a lot of inertia, right? Because first, do no harm, as the Hippocratic Oath says, and practitioners are usually slow to adopt newer means by which to manage conditions, for good reason. It is important to wait for clinical trial data to support use of various diagnostics and treatments, right? So history is full of inappropriate early adoption of treatments that turn out to be harmful for patients. That being said, I do think medical education on the limitations of standard cultures is lacking, and that is a very important awareness issue. So second question, how common is intracellular bacterial communities in the bladder? I would say short answer is we don't know. So although there's multiple studies conducted by independent groups, which is always a very good sign that an observed phenomenon is real, we've not done large enough studies to really get a true estimate of incidence and prevalence of intracellular bacteria. But clearly it occurs in a certain proportion of patients. So next question. Okay, where can EQUC be accessed? So for my patients, I use LabCorp, which definitely does EQUC. I'm not sure about other commercial sources for this testing. Certainly EQUC can be done as part of a clinical study, but that's obviously not ideal for most patients, because most patients are not going to enroll in a clinical study. When will the PCR test you develop be commercially available? Well, if I had my way, it would be tomorrow. Unfortunately, research takes a long time because you have to verify things. You have to secure funding, which is very challenging in this funding environment. So I do hope to publish our clinical findings hopefully in the next year or so. And we are actively looking into commercialization of this assay to get it out to patients as soon as appropriate. Okay. Next question, is fulguration for persistent UTI legal? Legal, yes, absolutely, at least in the US. So definitions of legal for medical practice are obviously very specific to a country. I think maybe a different way to answer it is it ethical? I would say that we definitely need more studies. And so that is important. But electrofulguration, it turns out, has been around for a long time. And actually, electrofulguration for other bladder lesions associated with infection that I didn't even mention is arguably part of practice. So there are lesions like malakoplakia, which are associated with chronic UTIs, which benefit from fulguration, right? So I think patient selection for electrofulguration is extremely important, and also your technique, right? So just to give you one example, some patients with chronic UTIs, if you look in their bladder cystoscopically, have very diffuse injection of their blood vessels, dilated blood vessels, likely from very diffuse inflammation. I would never electrofulgurate a patient with a bladder like that because, you obviously cannot cauterize the entire bladder lining. The patient will be in agony, and it's not going to help them. If one is going to pursue electrofulguration, you have to know what you're doing and what lesions you're going to target and what, in your mind, is and is not a good limit. And again, if I have a patient that I'm not convinced has UTIs, obviously I'm not going to electrofulgurate him. I also reserve electrofulguration for patients who've consistently failed other means of treatment. It's really not at all a first or even second line of treatment. Okay, next question. What do you recommend for chronic UTI treatment for patients who have C. diff? That is a great question and very difficult. So, something I didn't get into very much in this talk. I do think the audience is familiar with the concept that, antibiotics are very powerful, even very narrow spectrum antibiotics. And you can have severe side effects from them, such as C. diff infection, which can be life-threatening. So, managing chronic UTIs is no joke, especially when antibiotics are involved. The non-antibiotic approaches to managing UTIs, I think, are particularly attractive to patients who have a history of C. diff infection. And I do have some patients like that in my practice, and we try to heavily focus on those approaches. Intravesical antibiotics like gentamicin can also be very useful for patients with a history of C. diff because gentamicin in particular is not absorbed by the rest of the body. So gentamicin instilled directly into the bladder is highly unlikely to change the gut bacteria and increase C. diff risk. Okay, as an immunologist, what is the role of the immune system in persistent recurrent UTI? Excellent, excellent question. There's a lot to it, actually. So a tiny bit of this work is mine, but the majority of this work is by really brilliant other scientists. So first of all, it's very interesting that patients who are immunocompetent, in other words, patients who don't have any obvious immune system issues, can even get recurrent UTIs, right? When we get a cold, for instance, caused by a specific virus, our immune system has a memory for that virus, and you're highly unlikely, at least for a certain amount of time, to get reinfected with that same virus. Why does that not seem to occur with UTIs? Well, there's very interesting evidence showing that memory immune responses in the bladder are impaired. One of the theories as to why that might happen is if the immune system reacts too strongly to a pathogen affecting tissue, it can destroy that tissue, right? So you certainly don't want your immune system to destroy your bladder if you have a low amount of bacteria causing some cystitis, right? And so there's very good evidence that the immune system puts the brakes on the immune response with signaling molecules called cytokines, such as IL-10, to suppress this kind of tissue damage. Of course, it's at the cost, again, of potentially clearing the bacteria. Why would FMT work is the next question. Why would fecal microbiota transplantation work? So, in my talk, I focused mostly on intra-bladder reservoirs of infection as a cause of persistent or recurrent UTIs. The other major theory, which is also correct as to why recurrent and persistent UTIs can occur, is because the gut is a natural reservoir for potential UTI-causing bacteria. There is some early evidence by other investigators that in patients prone to recurrent UTIs, shortly before they get a UTI, there's a big bloom, an increase in that uropathogenic bacteria in their guts. So, this is related to the concept of the microbiome, the collection of microbes in and on our bodies that maintain health but can also cause disease. The theory is that, perhaps patients prone to recurrent UTIs are more prone to blooms of these uropathogenic bacteria because of imbalances in their gut microbiome, and that a fecal microbiota transplant can correct this imbalance. It's also called a dysbiosis. Now, again, fecal microbiota transplants are investigational. There have been some reports of very bad adverse outcomes for getting these transplants. So I would urge some caution in terms of that approach. What is the definition of persistent versus chronic UTIs? First of all, I'll say that definitions of UTIs are quite variable and inconsistent, even in the medical literature. In my opinion, there's not a really great nomenclature. There isn't great terminology that's shared across providers and specialties and patient groups. That is my long answer. It's not really an answer, but I think many times what people call chronic UTIs are persistent UTIs and vice versa. Okay. Next question, does E. coli mask other bacteria that standard cultures don't detect? Yes, absolutely. I think that can occur. Enhanced quantitative urine cultures have shown a higher rate of what's called polymicrobial infections, infections caused by more than one bacterial species. And again, standard cultures really are biased towards detecting E. coli, which I want to reemphasize is appropriate for most patients, right? Historical data suggests 90% of UTIs are caused by E. coli. So it makes sense that, when urine cultures are developed, that they were oriented towards detecting E. coli. But again, like any test, standard cultures have issues. Next question is, do you recommend chemical disinfectant lavage? Short answer is no. So there is, to my knowledge, a single paper, not a randomized trial, of, for example, installation of povidone iodine, which is a disinfectant. It was, I believe, for patients with neurogenic bladders, in other words, patients who have very little or no sensation in their bladders. I had one patient try it and they had a pretty bad adverse reaction. So I am extremely hesitant about patients instilling these substances into their bladders. Next question. How often do you repeat PCR testing when treating persistent or recurrent UTIs have continued to be symptomatic. So I will generally have patients on a week or two of antibiotics at a time before repeating testing if they're still symptomatic. And just to back up for a moment, I want to again highlight that if patients have consistently positive standard cultures, I use that. And if they don't, I'll use EQUC. And if that doesn't seem to help, that's when I use molecular methods. But I tend to repeat testing after 1 to 2 weeks of antibiotics, in part because of the importance of antibiotic stewardship, right? So one legitimate danger of molecular methods is that since most patients will have positive results, even if they don't have a UTI, some patients may end up getting overtreated with antibiotics and be exposed to increased risk of adverse reactions, allergic reactions, or C. diff and antibiotic resistance going down the road. So, I personally do not believe in treating patients for months at a time without constantly reassessing their symptoms and repeat testing. Let's see, which US labs can do low-grade CFU? So that's really more of a provider interpretation consideration, right? So for example, conventional cultures all over the world will tend to categorize CFUs in ranges. So over 100,000 is the highest, 50 to 100,000 is another common categorization. I think what is trickier is that when standard cultures show polymicrobial presence of multiple bacteria, it's often automatically scored as likely contaminants, and then not speciated. In other words, no further investigation is done. Does contamination of urine cultures occur? Absolutely. But I do think that there are some patients who truly have polymicrobial infections that are missed by standard cultures when the provider sees a polymicrobial presence and dismisses that automatically as contamination. We should not automatically assume all polymicrobial culture results are false positives, so to speak. What do you think of bacterial resistance antibiotics have done long term? It is a very significant issue, is the short answer. Again, that's why I'm not enthusiastic about putting patients on long-term high-dose antibiotics without frequent and regular assessment of how they're doing, right? If a patient has become asymptomatic, why are we continuing to give them antibiotics, for example? What are the PCR next-gen sequencing commercial laboratories you use? I use Microgen. I think a lot of this audience is familiar with that. So just to briefly highlight what these different companies offer in terms of testing. So Microgen testing has 2 stages. The first stage is PCR-based and attempts to get results back within a few days so that providers can manage patients before waiting for the more definitive second stage results, which is based on 16S ribosomal RNA sequencing. Now, what I like about Microgen, and again, I only use Microgen for appropriate patients, is that it, I think, can identify the widest possible range of bacteria amongst the various commercially available platforms. What I'm a little less enthusiastic about Microgen is its antibiotic recommendations. For instance, Microgen and some other companies look for the presence or absence of specific antibiotic resistance genes. But we know in microbiology that just because a bacteria has an antibiotic resistance gene does not translate directly into the bacteria being resistant to a particular degree, right? So that brings me to another test that I almost always get in combination of microgen, which is pathognostics testing. So pathognostics testing is only PCR based, and then it also does a very special form of antibiotic resistance testing. So, since pathognostics is only PCR based, it does not, in my opinion, detect the widest possible range of possible uropathogens. But what I really like about pathognostics is that it does what's called pooled antibiotic susceptibility testing. So conventional urine cultures, and again, this works for most patients, will take individual bacterial species identified, assuming a polymicrobial infection is seen and pursued, and test these individual bacterial species against one antibiotic at a time. Works for most patients. However, we know that bacterial species can actually cooperate during infection and also trade antibiotic resistance genes and basically help each other out in terms of survival. So what pathognostics pooled antibiotic susceptibility testing does is it takes whatever bacteria are present in the urine and tests it against individual antibiotics. And I think that makes a lot of sense for the right patient. What's really interesting is that even though pathognostics and microgen are fundamentally different platforms, it's surprising how often these independent companies identify the same bacteria. So when they do, my level of confidence in those results is much higher. Let's see, what is your perspective on biofilm busters? Yes, I'm glad someone asked that. So short answer is biofilm busters don't work, unfortunately. The reason is this. So although the components of biofilm busters make sense in terms of potentially breaking up biofilms, since these supplements contain enzymes that would break down common components of biofilms. Enzymes are proteins, and these biofilm buster capsules are taken orally. So as soon as you swallow these capsules and they hit the stomach acid, these enzymes get destroyed. So basically, these enzymes never get to where they need to, unfortunately. Would biofilm busters work if instilled into the bladder? Maybe, but I would caution that there's really been no studies of this, and I would not recommend it outside the setting of a clinical trial. Next question, do you do biopsy and send for tissue culture before electropulgration? I do not. I sort of draw the ethical line on doing routine biopsies on patients with UTIs. The reason being that we know these inflammatory lesions have a very high rate of harboring bacteria. And bladder biopsy is not totally benign, right? There are risks of bleeding or even bladder perforation or in and of itself causing a UTI. So outside of a clinical study setting, I personally don't think bladder biopsy is routinely indicated for UTI patients. Unless you see something very weird or you're concerned about bladder cancer or something along those lines. Okay, can you discuss the difference between intracellular colonization and biofilm? Okay, so intracellular bacterial communities, IBCs, have been described as biofilm-like intracellular collections of bacteria. So, but to back up for a moment, what is a biofilm? So first of all, biofilms have been implicated in the vast majority of human infections, okay? They're clearly important in terms of bacterial persistence and recurrence in various infections, including, in my opinion, UTIs. That being said, there are no really good validated means by which to detect a bacterial biofilm. So for instance, you would have to do a bladder biopsy, and you also would have to preserve and process that biopsy tissue in a very specific manner to diagnose a biofilm. And again, I don't think bladder biopsy is ethically indicated in most patients. A biofilm is a collection of bacteria in a community, often more than one species, that lives in a slime, right, of various carbohydrates, for instance, and proteins. And there's very compelling data showing that this slime allows bacteria to survive antibiotics that they seemingly would be susceptible to based on testing in the lab, and may be a means by which they avoid the immune system as well. Biofilms are classically pictured as being on surfaces, including on tissues. So in the bladder, for instance, a biofilm would form on the bladder lining. But again, there's very good evidence that in addition to biofilms, bacteria causing UTIs can burrow into the urothelial cells lining the bladder. Okay, can some patients with persistent lower urinary tract symptoms have chronic urethritis? Would testing and treatment options be similar to that for persistent recurrent UTIs? Yes, I do think that some patients, probably an unknown proportion, diagnosed with things like overactive bladder, may actually have chronic urethritis. I think testing and treatment options would be similar for that for cystitis, as I outlined earlier. It is a little bit challenging diagnostically because it's difficult to sample the urethra unless you did a swab without also sampling the urine. But clearly chronic urethritis is one form of UTIs that certainly deserves treatment when it has an infectious basis. What is the recovery time after fulguration, and what situations would require repeat fulguration? So the most common patient symptoms I've had reported to me after fulguration is a day or two of bladder heaviness. And then the vast majority of patients seem to very rapidly recover after that. Again, my personal experience with electrofulguration is limited because I'm very cautious as to who I perform electrofulguration on. I have not personally done repeat electrofulguration on any patients. Would I consider it? Yes, for the right patient. If they have recurrent symptoms, perhaps negative cultures but positive molecular testing, and have appropriate bladder lesions seen on cystoscopy. Really, the person who has the most published experience with repeat electrofulguration is Felipe Zimmer, who's a very prominent urologist at UT Southwestern, former president of Society of Urodynamics and Female Urology, et cetera. Next question, what are your thoughts on ozone gas insufflation? So I'm very happy someone asked about this. To my knowledge, there's really no clinical trial evidence to support this practice. And given how toxic ozone can be to tissues, I'm extremely hesitant about patients who use ozone installations. Could I be proven wrong? Yes, absolutely, but the data is not there to support its use. Next question, how long do I ask patients to be off antibiotics before testing by molecular methods? If a patient is symptomatic, I actually have them continue the antibiotics, although microgen and pathognostics testing is occasionally negative in patients who are still on antibiotics. Most of the time, it will still come up positive. If a patient's not symptomatic, yes, having them off antibiotics for a few days to increase the sensitivity of molecular testing is probably a good idea. Next question, what percentage of UTI patients have diverticuli or other physiologic causes? How do you treat in those circumstances? So there have been good studies done by others showing that the majority of women with recurrent UTIs do not have apparent physiologic or anatomic causes for their UTIs, including diverticuli or bladder dysfunction. For patients who do have anatomic or physiologic causes for their UTIs, treatment is very specific, right? So, for example, some patients, most do not, but some patients have stones that they didn't know about, and some stones can harbor bacteria. Those are called so-called infection stones. Obviously, a patient with infection stones and a history of UTIs, it makes sense to consider lithotripsy to get rid of those stones. Next question, how do you select for electrofulguration candidates as opposed to longer-term antibiotics? Ultimately, it's a judgment call. Again, I really reserve electrofulguration as one of the last lines of management. But, for example, if a patient has tried multiple antibiotics and has been weeks into it, not really improved, those patients, it makes sense to at least have the conversation about electrofulguration and if it might make sense for them. How common is fungal or viral bladder infection? How do you test for these? So most patients with UTIs are immunocompetent, as I mentioned earlier, meaning that they don't have any obvious issues with their immune system. That being said, they don't have obvious issues with their immune system as tested by peripheral blood. There is a little bit of evidence that there are local issues with the bladder immune system. That's a whole nother discussion. So because most patients are immunocompetent and most viral and fungal bladder infections occur in patients who have a chronic catheter or are immunosuppressed, I think it's a very small minority of patients who have occult viral or fungal infections as a cause of their symptoms. It does happen, especially in children. Children, it's well known, can get viral cystitis. What is assumed, I think, is that, by the time we're adults, we've been exposed to those viruses and have a memory immune response and are no longer prone to viral cystitis from those particular pathogens. How do you determine which bacteria for microgen and other testing could be problematic and causing symptoms versus bacteria that's just present that isn't causing symptoms? It's very difficult, right? We now know that because of these molecular testing methods, but also more fundamental studies, that urine is almost never sterile, right? So the big challenge is if everyone pretty much always has some bacteria in their urine and it's normal, how do you know in a patient that does have symptoms which bacteria are causing the symptoms? We don't know without empiric treatment, unfortunately. So meaning that you try an antibiotic based on your best judgment and discussion with the patient and see how they do. And I would argue that when you get polymicrobial results on a conventional culture or EQUC, you're facing some similar issues, right? Do you give antibiotics that cover everything? Do you give antibiotics that just cover what you think is the more likely pathogen? What are your thoughts on broth culture testing available in the UK? I think we need more studies. Studies need to be pretty large scale to validate new diagnostics, let alone treatments. Next, do IBCs exhibit quorum sensing? What a great basic science question. Quorum sensing refers to the ability of bacteria to sense other bacteria and alter their behavior, such as growth, based on that. So for example, bacteria know when it's kind of crowded in an environment and adjust their biological behavior accordingly. There is evidence that IVCs exhibit some quorum sensing. So for example, there are limits to how many IVCs you'll find in a single urothelial cell. I didn't get into this earlier, but IVCs have this life cycle where they can have the bacteria come out as filamentous bacteria and cause planktonic infection, and then eventually potentially settle back into IVCs. And this is almost certainly related to quorum sensing. Are there any genetic mutations that can predispose to UTIs, such as PAI1? So I'm not convinced there's good evidence for PAI1, but there is evidence for other genetic polymorphisms, as they're called, variations in genes that contribute to UTI risk. So for example, Tony Schaefer a few decades ago showed that certain blood group antigens seem to be associated with increased UTI risk. And that might seem weird, why would blood proteins increase your UTI risk? Well, it turns out that urothelial cells express some blood group proteins as well, including the ones that seem to be associated with increased UTI risk. So it seems to me that at least in that example, certain genetic polymorphisms make your urothelial lining of the bladder stickier for bacteria. There's also almost certainly, in my opinion, not a lot of data to support this, that other genetic polymorphisms may be related to the local bladder immune response would confer increased UTI risk. If a patient has a stone and UTI, does the size matter, or should be treated regardless of size? I think we have to be a little bit thoughtful about pursuing every single stone in a patient who has a UTI, mostly because most stones are not infection stones, and stones are very common, and so are UTIs. So the likelihood that you will see a UTI patient who also has a stone incidentally is not insignificant. Really, I think stone management, if you don't think it's an infection stone, should be based on patient stone-related symptoms, size, anatomy, etc. Are there supplements you recommend to heal the bladder that's been injured by UTIs? Unfortunately, I don't think we have much in terms of options to promote bladder healing. There are a few studies, and I think I mentioned this earlier, suggesting that instillation of hyaluronic acid, which is found naturally in the bladder lining, can help reduce chances of recurrent UTIs. And I do think that some patients, the few patients misdiagnosed with IC but actually have UTIs and then end up getting installations of local anesthetic and some steroids, I think some of those patients improve because the installation ends up promoting bladder healing. And then related, how do you diagnose IC versus UTIs? Yes, so IC, the classic definition is patients who have negative cultures. Of course, this is all based on conventional cultures, don't have another anatomic or physiologic explanation for urinary urgency and pain that increases with bladder filling and gets better with voiding. Classic IC is also often associated with flares of symptoms, waxing and waning of symptoms. There's two forms of IC. There's the ulcerative form and the non-ulcerative form. The ulcerative form is a pretty straightforward cystoscopic and biopsy-based diagnosis. Unfortunately, that is the minority of patients with IC. I think the big challenge of diagnosing IC versus recurrent UTIs is that since most IC patients don't have these ulcers and there is potential overlap in symptoms, there almost certainly is an unknown proportion of patients misdiagnosed with IC who have UTIs and vice versa. There are some older tests that are not universally accepted, like potassium installation into the bladder, which I'm personally not enthusiastic about. And you could do urodynamics, but again, IC unfortunately is in part a diagnosis of exclusion. I think things that can distinguish UTIs from IC, if a patient tells me they consistently improve on antibiotics and that they've always had positive cultures or almost always have positive cultures during those episodes, I think those patients are probably unlikely to have IC. That being said, patients with IC sometimes can also get UTIs. But one thing that's very interesting to me is that patients with IC describe typically a very different pattern of UTI-associated symptoms than their typical IC symptoms. How significant is the anti-inflammatory effect of some antibiotics? I think that is a really important consideration that we don't know too much about. There are a few pretty compelling studies showing a number of antibiotics have anti-inflammatory properties. And yes, I do think it likely accounts for some or a lot of the effects we see in patients. The magnitude of that effect, I don't know. There's also evidence that some antibiotics affect the neural networks in the bladder in a positive fashion. So that may also be another potential non-bacterial based mechanism by which antibiotics can work. So, frankly, that can confuse the picture. If a patient is not having UTIs and they have some improvement with antibiotics, it is a possibility that that effect is non-bacterial. Do the risks of cystoscopy outweigh the benefits in patients with negative standard cultures? It is a good question. Again, there is literature supporting that the majority of at least women with recurrent UTIs do not have cystoscopic findings. So although I talk to my patients about cystoscopy, especially if they're not doing well on antibiotics, I think the vast majority of time, and this has been my experience, cystoscopy doesn't really contribute to management. And I think, okay. Here we see another question. Is positive response to antihistamine an indication of IC? That's a strong maybe. So there is both data that mast cells, which are immune cells that release histamine when activated, are present in some patients with IC in their bladders. And so it makes sense that antihistamines helps this subset of patients, but there is also emerging evidence that mast cells play a role in UTI pathology. So that's, I'm thinking of Soman Abraham's work, which granted is fundamental research in mouse models, but there's a little bit of work on mast cells in humans as well. And I think that's the end of the questions so far.
I think that's it. Dr. Hsieh, thank you so very much for this presentation and for having stayed 17 minutes over time with us answering all of these many, many questions. Just a note for everyone. I'm just going to try to share my screen quickly. Here we go. So you can find more information about this at urgemedical.org. Oh, hold on, sorry, wrong button. You can find more information at urgemedical.org. and the / about persistent UTI. And there's also going to be a recording of this that's going to be uploaded onto the website, so keep an eye out. We're also in the process of setting up a Facebook group for MDs and researchers, so keep an eye out for that invitation. And the next event is going to be in the new year in about 6 to 8 weeks, and keep an eye out for future invitations for future events. And if you have any questions or comments or thoughts or anything that you'd like to share, you can reach us at hi@urgemedical.org. And that is it. So thank you everyone for joining, and thank you once again so much, Dr. Hsieh, for sharing this really important information with us and for taking the time to speak to us this Saturday.
Yep. Thank you, everyone.
Thanks. Have a great afternoon, everyone. Bye-bye.